Danielle, are we good to go? Or attendees?
Great.
Cool.
Yeah, people will probably keep joining the next handful of minutes, but I think we're good to go.
Okay, so I guess we'll go ahead and get started. We're starting off with a CFAR New Faces talk. So for those who are new to the CFAR seminar series, the CFAR seminar provides a forum for presenting and discussing state-of-the-art HIV findings in pathogenesis, virology, care, and treatment, provide an opportunity for communication and collaboration across HIV researchers in the CFAR institutions and their partner organizations. The next CFAR seminar will be on June the 2nd, and we'll also have a New Faces talk preceding the full seminar. So today for our New Faces speaker, I'm delighted to introduce Dr. Payal Patel. Dr. Patel is a pediatric neurologist specializing in neuroinfectious diseases. She received her MD from Baylor College of Medicine and did her residency in pediatrics at Dell Children's Hospital and neurology from Children's Hospital of Philadelphia, followed by a fellowship in pediatric neurology from Yale School of Medicine. She's currently an acting assistant professor here at the University of Washington in the Department of Neurology, and her research is focused on neurologic sequelae resulting from infections of the nervous system in adults and children, including perinatally acquired HIV. She's a new collaborator and new face for me is for sure in the University of Washington. So I'm very delighted to meet you and to hear about your work.
Thank you so much for the lovely introduction. I am going to speak today about some of our work in cognition in individuals living with perinatally acquired HIV, and really try to highlight some of the challenges, especially when we're looking at HIV for really long durations across various stages of life. This work is supported by my K23 award from the National Institute of Mental Health. So first, we'll review kind of a broad overview of the pathophysiology of neurologic injury occurring in all individuals living with HIV. And then we'll take a deep dive into the published literature that tries to define cognitive impairment and risk factors for cognitive impairment in individuals living with perinatally acquired HIV. And then briefly delve into some of the challenges in looking at change in cognition over time in this cohort. If we have time, I would love to dive into some of our work looking at neuroimaging markers of cognition in individuals living with perinatally acquired HIV. So what we do know about HIV in the CNS is that HIV enters the CNS very early in acute disease. Within the first week or two, we found evidence of viral replication occurring in CSF in individuals with acute HIV. Once it enters the central nervous system, it sets up an ongoing immune activation cascade, which promotes further neurologic injury. And in certain individuals, the virus itself becomes compartmentalized, meaning that there is a genetically distinct virus within the CNS space. And the persistence of this virus has strong implications for HIV cure as a reservoir that is essentially resistant to treatment. In children, the dynamics are a little bit different in that children actually have a more permeable blood-brain barrier at birth, meaning that HIV could enter the CNS space even earlier in newborns. HIV has also been shown to disrupt synaptic formation and to produce infection in neuronal progenitor cells, which have distinct implications for the developing brain. The immune-mediated mechanism of neuronal injury in HIV is presumed to be through two different mechanisms. The first is the Trojan horse mechanism, where HIV hijacks a leukocyte. That leukocyte transverses the blood-brain barrier, which is depicted here in this pictorial diagram. And then that's how HIV can enter the CNS space. HIV can also cross the blood-brain barrier independently, and HIV-related proteins can also promote inflammation here. What we don't really know, and hence the question mark here, is whether or not monocytes also transverse the blood-brain barrier, HIV-infected monocytes also transverse the blood-brain barrier, or whether HIV infection itself actively infects microglial cells, which is the monocyte variant within the CNS space, producing productive inflammation there. And it is really this monocyte mediated, microglial cell mediated activation that is the primary source of neuronal injury in individuals living with HIV. Specifically to individuals living with perinatally acquired HIV, there are a lot of other factors that influence cognition. So it's really difficult to study in isolation the effects of HIV on the developing brain. And these factors include stigma, substance use, parental loss or illness, and also in utero drug exposures, both to ART and to recreational drugs, and other perinatally acquired infections, specifically CMV. So now that we talked a little bit about, what we believe is occurring as the mechanism behind neurologic injury, we'll take a look at what the cognitive profiles are of individuals living with perinatally acquired HIV. A meta-analysis of an international group of HIV positive, perinatally acquired HIV positive cohort studies compared to uninfected and unexposed controls, here's the HUU, and compared to HIV exposed in utero uninfected controlled, showed a wide array of differences in cognitive scores, with some cohorts, falling below meaning significance. But what we did find when we compared all of these studies is that there were consistently lower scores in the HIV positive group compared to local HIV exposed and unexposed uninfected matched controls, particularly in the working memory, executive function, and processing speed domains. We also know that the HIV disease severity significantly impacts cognition, in that those that have a prior history of an AIDS-defining illness have lower scores. This study was out of the pediatric cohort, and it showed that there was higher rates of cognitive impairment, which was defined as scoring 2 standard deviations below the normative mean across multiple domains in individuals in this medium gray bar here, individuals living with perinatally acquired HIV who met the CDC Class C classification or who had a history of AIDS-defining illness. In children who were treated with antiretroviral therapy, children who did not have this AIDS-defining illness history had similar scores compared to the HIV-exposed uninfected peers. So does that mean that early initiation of antiretroviral therapy is beneficial in protecting children against the development of cognitive impairment? So the SHARE trial, which was a trial looking at randomization of early initiation of antiretroviral therapy in infants less than 3 months of age, attempted to answer this question. And what they found at their 11-month cross-sectional time point is that in the children that received immediate antiretroviral therapy, which are the orange and green bars here, there were significantly higher scores in this general Griffith score, which is a score for development, compared to those that were in the deferred arm. The deferred arm received antiretroviral therapy when they met certain metrics of immunosuppression. But when they followed these children out long term to the 5-year mark, there were no differences between those that started antiretroviral therapy early versus immediate, even compared to the exposed uninfected and unexposed uninfected controls. There are a few limitations for these studies. They are low powered, meaning that each subgroup has only less than 40 individuals, When we use these cognitive tests, they're based on British norms, and so we didn't have local norms. And none of the children were on continuous antiretroviral therapy. The children that were in the immediate arm were also part of an interruption trial. And so we can't really answer this question about the benefit of early initiation of antiretroviral therapy and continuous antiretroviral therapy in infancy. So to summarize thus far, what we know about cognitive outcomes in youth perinatally acquired HIV is there are consistently low scores when compared to local uninfected populations. Children with a history of prior CDC Class C diagnoses for AIDS-defining illness have worse cognition. And early initiation of antiretroviral therapy may be beneficial, but really the longitudinal studies still need to be done in order to really clearly define this benefit. So we also have a cohort in Thailand and Cambodia called the PREDICT cohort. The PREDICT cohort was a larger study looking at early versus early initiation of antiretroviral therapy, or at the time of diagnosis, versus deferred initiation of antiretroviral therapy and immunosuppression decades ago in children living with perinatally acquired HIV in Thailand and Cambodia. They were enrolled between the ages of 1 to 12. And they were randomized to this immediate versus deferred antiretroviral therapy initiation. As a sub-study, some of the children received cognitive testing annually. And here are the lists of cognitive tests that were available. Because of the study design, we had a lot of variability in who received what test at what age, because there's a wide age range of enrollment. And over time, who was on antiretroviral therapy and virally suppressed based on the enrollment criteria of immediate versus deferred ART initiation. So in this really kind of complicated, large cohort study, we tried to assess longitudinal cognitive outcomes using a novel statistical analysis tool. And that tool is called group-based trajectory modeling. So group-based trajectory modeling uses Bayesian information criteria to determine clusters of classification cohorts within a larger cohort. And so we did this in our cohort for all individuals that had at least 3 years of cognitive testing. And across all of the different testing subgroups that we mentioned before. Consistently in each of these test subgroups, we found 3 trajectory groups, which we defined as high, medium, and low scoring groups. We then sought to assess change over time, and we used the definition of greater than 0.5 standard deviations of change in the score across the age range in order to define a clinically significant change in scores. What we did find in our groups is that most scores were stable over time, with 2 exceptions, and that's for verbal IQ, in which case all 3 score groups fell by about 10 points across age. And in the Color Trails test 1 and 2 trajectory groups, this is a test for motor function and executive function, the highest scoring group actually had improvement in scores over time, whereas the medium and low scoring groups demonstrated stable scores. We then looked at predictors of belonging to the lowest scoring trajectory group, and we accounted for age, median household income, immediate or deferred ART initiation, CD4 nadir, and who the primary caregiver was. This was a multivariate analysis, and any variable that reached significance of P less than 0.15 were included in this multivariate analysis. And we found that significant predictors of belonging to the lowest scoring trajectory group were older age, greater than 8 years of age at enrollment, poverty, which was defined as having an average household income below the median national average, and having a biologic parent as a primary caregiver was actually a protective factor, meaning not having a biologic parent was associated with belonging to the lowest scoring trajectory group. So in summary, group-based trajectory analysis allows us to visually display the continuum of cognitive outcomes within a cohort. Most trajectory groups actually scores remain stable across age in trajectory groups. Verbal function appeared to decline, but I feel like this may be a factor of the test itself rather than verbal function, especially because we were using English-based tests on non-native English speakers. The highest scoring subgroup in the Children's Color Trail Test 1 and 2 had an increase in scores, and this increase in scores is what we typically expect to see in development. And so this may represent a subgroup with better cognitive reserve. Importantly, social determinants of health and longer duration of untreated HIV may predispose children to suboptimal cognitive development. So now I'm going to take a second to talk a little bit about white matter injury in perinatally acquired HIV. So the SHARE trial, looking back, did show evidence of what we call white matter hyperintensities, which are these kind of juxtacortical little ditzels that you see here and here that we very commonly find in individuals living with HIV and have unknown clinical significance. In the SHARE trial, which is separate from this study, they found this in 50% of children living with perinatally acquired HIV, but did not demonstrate an association between this finding and development. This is another study out of South Africa, also with children with perinatally acquired HIV who were virally suppressed, and they found white matter hyperintensities or white matter lesions in 7 of their 34 participants, 2 of which demonstrated arteriopathy, which is thinning of the blood vessels, as you can see here and here. And in this study, children with perinatally acquired HIV and these white matter hyperintensities or white matter lesions had a worse global deficit score, which is another metric of cognition, compared to children without these findings. Diffusion tensor imaging is a method of an MRI technique that measures water molecule diffusion surrounding the myelin of an axon and can give you a metric of white matter integrity. These are metrics that you get from diffusion tensor imaging. Fractional anisotropy and diffusivity metrics. Lower fractional anisotropy and higher diffusivity means poorer white matter tract integrity. So across all of these cohorts of children with perinatally acquired HIV who also had matched uninfected controls, you see decrease in fractional anisotropy in the whole brain and regionally. The diffusivity metrics get a little bit more tricky when trying to interpret. Globally, you see an increase in diffusivity, but there is a lot of regional variability and a lot of within cohort variability with this metric. So in summary, we do see imaging findings of poor white matter integrity, some of which are associated with cognitive performance in individuals living with perinatally acquired HIV. There's a lot of variability between studies, and a lot of this is related to the poor reproducibility of particularly diffusion tensor imaging as an independent clinical imaging biomarker. And importantly, white matter hyperintensities and diffusion tensor imaging do not give us an idea of what the actual microstructural changes are that are occurring in white matter. So my current study in K23 study is looking specifically at this in adults living with adults living with perinatally acquired HIV who are virally suppressed. We're using an imaging metric called Myelin water imaging, which essentially uses the differential relaxation time between water trapped within the myelin bilayer and extracellular and intracellular water to give you a myelin water fraction, which is a way to extrapolate myelin content. Myelin is the fatty lipid bilayer that is wrapped around axons that is part of the white matter infrastructure in the brain. This imaging sequence has been well validated in multiple sclerosis. So here is a regular conventional MRI sequence which shows white matter hyperintensities. They correspond to these dark regions on the myelin water imaging sequence. And Luxol fast blue is a type of pathologic stain on a brain section, which stains for myelin. So you can see well-myelinated regions here, and the areas of white matter lesions that have loss of myelin also have loss of myelin on the path tissue. And here demonstrates the correlation between myelin water fraction, that imaging metric we discussed before, and the path density, the Luxol fast blue optical density. So in our study, we enrolled individuals over the age of 21 who are diagnosed with HIV in childhood, although not necessarily required to have a perinatal diagnosis, as a lot of patients were adoptees and had their HIV diagnosed in early childhood. And they had to be on a combination antiretroviral therapy for at least 6 months. Exclusion criteria were viral load greater than 500 copies, active CNS infection within the last 3 months, a known neurologic condition unrelated to HIV, an HIV transmission that was known to be related to a non-perinatal cause. For the neuroimaging study, we also had a contraindication to MRI scan or any history of opportunistic CNS infection were an exclusion criteria for the neuroimaging piece of the study. We currently have 17 participants enrolled in the study, and here are the demographics of our participants. Most had an undetectable viral load, and the viral load ranged from not detected to 222 copies. Well, we found 8 of our participants underwent myelin water imaging. When we compared myelin water fraction values to HIV uninfected age and sex match controls, we found decreased global myelin water fraction and decreased frontal lobe myelin water fraction in our cohort of adults living with perinatally acquired HIV. We also found that there was a strong correlation between global myelin water fraction and executive function scores, meaning higher executive function scores correlated with higher myelin water fraction, demonstrating that the decrease in myelination may be the pathologic substrate that underlies poor cognition in individuals living with perinatally acquired HIV. This is a study that's currently enrolling, so I look forward to presenting more detailed regional analysis in this cohort once we enroll more individuals. Now I have a few minutes for questions.
Thank you so much, Dr. Patel. If anyone has questions, you can put them in the Q&A box or in the chat box, and I can unmute. a quiet group. Oh, there's one in the Q&A. There's a question from Genevieve Mezzo. Any idea how HIV enters directly across the blood-brain barrier?
I actually don't know the answer to that question. I think it's able to just transverse across the blood-brain barrier, but I don't have a specific answer to that question.
Well, I have I guess if nobody else has a question, I have one. You mentioned that one of the issues in comparing the different studies was that some of them were questions were in English, whereas the cohorts were across the world. And I was wondering if you have any thoughts on how to, because this is not my field at all, but I'm wondering how does one reconcile that in international cohort studies like the ones you're describing?
Yeah, so now a lot of work has been done trying to replicate the same test, but in a culturally sensitive manner, right? So there's a lot of now adaptations to studies, cognitive tests that have existed, but adapted to more familiar language, more familiar terminology, what children may be more culturally exposed to. And then what they do is they develop these tools and then they cross-validate it in healthy children. They establish norms in the healthy group, and then they take these tests to children living with perinatally acquired HIV and then use those standardized norms to assess cognition. So a lot more work has been done since the studies that I had showed have been published with validation metrics. We're still waiting on that results in the HIV positive group to come out, but the validation of the testing tools has been done.
Thanks. Are there any other questions? Thanks for sticking to the time as well. It's,
of course.
move on. And yeah, if there's no other questions, Dr. Silvestri, our speaker, had a hard